Hello. Good evening, everyone, and a very warm welcome to all of you to the Global Business School for Health and to our fifth Transforming Health Systems dialogue series, Conversations That Matter. My name is Madhurima, and I'm a research fellow at the UCL Global Business School for Health. I would like to extend a warm welcome to everyone joining us here in person at UCL East, as well as to colleagues online from different parts of the world. Thank you all for taking the time to be with us today. Today's conversation, Shifting Terrain, Agendas for Health Policy and Systems Research in a Time of Critical Global Change, comes at a particularly important moment where health systems are being reshaped by multiple intersecting challenges. This discussion also contributes to wider ongoing conversations linked to the forthcoming research handbook on health systems in the Global South, which seeks to advance critical and globally grounded perspectives on health systems research and practice. We are delighted to have an outstanding group of speakers with us today. We are especially pleased to welcome Professor Irene Agyepong, who joins us as our lead discussant. Our moderator for this evening is Professor Kabir Sheikh, Professor of Global Health Systems and Policy at UCL and Director of the UCL Center for Global Health Systems and Policy. Professor Irene Agyepong is internationally recognized for her contributions to health system strengthening, governance, implementation research, and health policy in the Global South. We are also joined by an excellent panel, Professor Tolib Mirzoev, who has joined us in person. He's a professor of global health policy, London School of Hygiene and Tropical Medicine. His work focuses on health systems, policy and strengthening, particularly around governance, workforce implementation, and systems learning. We are joined online by Dr. Rene Loenson, Director of the Training and Research Support Center in Zimbabwe. She has made significant contributions to work on health equity, social determinants of health, community participation, and people-centered health systems. Dr. Keith Cluett, Head of Department at the Western Cape Department of Health and Wellness, South Africa, has also joined us online. A health systems leader and policymaker from South Africa with extensive experience in health systems governance, health sector reform, and translating evidence into policy and practice. And finally, Dr. Mariam Bigdili, a health system specialist, former WHO representative, and head of mission at Morocco. Her work has significantly advanced understanding around access to medicines, health commodities, and the ways in which pharmaceutical systems interact with broader health systems. Before we begin, just a few brief housekeeping notes. As this is a hybrid event, we warmly encourage participation from both our in-person and online audiences. For those online, please feel free to use the Zoom chat to submit your questions and reflections during the session. We will try and bring these into the discussion during the Q&A segment. With that, thank you once again, and I call the in-person panelists here, Professor Kabir Sheikh, Professor Irene Agyepong, and Dr. Tolib Mirzoev. It is now my pleasure to hand over to Professor Kabir Sheikh to begin today's conversation. Thank you.
Thank you, Madhu. So there's a bit of housekeeping. We can only use one mic at a time, so I'll switch mine off. Thank you so much, Madhu, for the introduction. So can we have the slide, please? Welcome, everybody, to the fifth Transforming Health Systems conversation. Yes. The mic is on, yes. So I just wanted to start by prefacing that the conversations are supposed to be a dialogue across different groups, not just an academic talk, but a conversation involving practitioners and policymakers from different walks of life. So this talk, although it's focused on research, is very much in that vein with some of our panelists reflecting on those experiences. And Irene as well is somebody who's very much bridged that sort of divide between research, policy, and practice, as is Professor Mirzoev and all our other collaborators and colleagues here today. So the topic is Agendas for Health Policy and Systems Research in a Time of Critical Global Change. And I was just up on the balcony today with Irene, and we were reflecting on whether this time is indeed unique. Is it, sort of, does every generation think that, oh, the world is ending and everything is changing and everything is going badly? And we reflected that maybe we shouldn't really have that mindset. Yes, of course, the world is always changing, but there are a particular set of changes that are happening now, and we thought that we could reflect on those a little bit and go into depth about those. And then think a little bit about the field of health policy and systems research, which really evolved over the last 30, maybe 30 to 40 years. There have been a few milestones along the way: the establishment of the Alliance for Health Policy and Systems Research, the emergence of Health Systems Global, of which both, actually all three of us have been chairs at different points in time, and the emergence of a number of journals, specialist journals in this field. So it's an exciting time for the field, and I think it's a good time for us to think about how we might approach these big changes that we're experiencing as purveyors or practitioners of this field of research. So I just wanted to start by presenting this this little figure that you can see up on your screens. Sorry, I'm sorry if the banners are blocking the view, but just maybe it's yeah, that one's better. So what we're trying to demonstrate here is that a lot of our attentions tend to get focused on the right side of this image. I'm going to stand up so I can see it better myself. So on the right side of the image, we see big headline topics like climate change and epidemiological changes, pandemics, and so forth. We see digitalization capturing all the headlines. And then there are other themes which are also equally important, but don't really capture the headlines to the same extent, such as urbanization, which is actually probably the biggest social phenomenon we are seeing in low and middle income countries, where entire countries are transforming from rural economies to urban economies. And of course, the other big trend that sometimes goes a little bit unnoticed is the expansion of private markets. And I think we're very familiar with the existence of pluralistic health systems in many countries. But what's happening now is even the manifestations of that private expansion are changing. And we see that through trends such as financialization and the expansion of private equity. So that's worth reckoning with. And of course, the somewhat related theme of misinformation and disinformation, which I think it's important to talk about as a health systems issue and not just as an informational issue, because I think there are a number of political and systemic reasons for why we see the misinformation and disinformation spreading worldwide. So while we get occupied with these issues, these new emerging challenges on the right side of the spectrum, we can't forget that the world hasn't yet solved the old problems, right? So we still have the same challenges. In many cases, of course, there has been huge progress and strides in all of these areas, but these issues still remain the same as they've been for probably the last 100 years, if not more. And those are, failures related to governance, failures related to the way we look at the health workforce and how it can really be optimized, difficulties in aligning health financing with the goals of people and health systems and people's needs. And this phenomenon of that we always tend to neglect primary health care at the expense of secondary care and hospital care. And then the global problem of exclusion. There are always people who sit on the outside of health systems, the liminal people, and nothing describes that, demonstrates that better than the way that migrants get treated in many societies and how health systems can exclude them. And that's underlined by the increasing conflicts that we are seeing. So that's just a way to start our conversation off. It's a big canvas, but maybe I can invite Irene in the first instance to react to that a little bit and give us some thoughts, and then we'll go into the different breakouts.
Thank you, Kabir. I think, like you've said, you could get discouraged, but it's better to. But it's. I think the French say plus ça change, plus c'est la même chose. I think Solomon put it another way. There's nothing new under the sun. The sun rises and it hurries back and it sets and it rises again the next morning. It also helps sometimes to, even as you try to resolve some of these problems, to take that attitude which gives you hope rather than despair. I don't think we are going to radically transform the world, but we can try to make it a little better and not contribute to making it worse. So that's kind of what I will add on, because sometimes when you see a diagram like this, it can look kind of depressing. And as I was coming in, I saw it was on the other floor. There was this whole thing about mental health. And I thought, yes, this is very appropriate. So maybe just to start on a note that keeps our mental health protected and we hope rather than despair.
Thank you so much, Irene. I think also we need to think a little bit about how scholarship and research can contribute to hope rather than despair. So I think a lot of our scholarship has been focused on diagnosing the problems. And maybe we need to think a little bit differently about how we also think about contributing to the solutions more actively. So we could move into the first theme now. Do we have both? We have Talib sitting with us, of course, but do we have Mariam online? Mariam, would you mind putting your camera on?
Yes. Good afternoon. Do you hear me and see me?
Yes, we do. Thank you. Welcome.
Okay, great. Thank you very much.
Okay, so the first theme, and I will happily hand over the mic to our respondents after the question, is what are the implications of changing political and economic conditions, including all of those issues that we mentioned, geopolitics, declining yield, new forms of commerce, AI, and misinformation, on how we think about priorities, the agenda for health policy and systems research. Should we be changing the types of questions we're asking? Should we be focusing on a different sort of agenda for the field? Let me first invite Mariam and then Talib.
Yes, thank you very much, Kabir, for this excellent webinar and for inviting me to take part in this. This is a super interesting discussion because I really was afraid that we would start off the discussion with saying that we are living through unique times and I'm really happy to hear that both you and Irene insisted on the fact that there are problems there that are as long as health systems exist, as old as health systems exist, and that we need to not be discouraged in the face of those problems. So that's for one thing, but I mean, we really have to also get back to what we have done and not done, and also acknowledge that maybe we have repeated for decades that we needed to focus on certain aspects of frontier and innovative health policy and system research, such as looking at power relations and integrating political economy and those analytical frameworks in our health system work, and deeply engaging with issues of fragility and crisis in health systems. And we've done that time and again. But I think that right now we need to really look back at those methods that we have used in certain conditions and see if we can up that game and use those methods and approaches more systematically and more widely across health systems, even if they are not so-called in a fragile condition such as a war or a major disruptions, because I think that I believe that most health systems now are under a certain form of disruption. So we're talking about numerous fragmentations in health systems, with regional alliances coming up, with weakened multilateral institutions, and many health systems turning their back to multilateral institutions, and one example is the US, the United States. So it's not just like countries at war or countries with very fragile health systems, but also countries with so-called stronger health systems that are seeing these fragmentations, and that has an effect, as we know, around the world, with limited resources, with fragmented health markets as well, sort of like also different kinds of commerce coming in, hybrid commercial systems around health commodities, and a lot of political interests that are now increasingly dominating the power relations in health systems. To those existing problems adds now, I think, two very important issues that are indeed newer than others. These are climate change and digitalization. And while I think climate change is really something that we need to be worried about, and I agree with Irene that we need not to be discouraged, and we need to hang to things that are giving us hope. I still believe that we are not dedicating enough time and attention to analyzing not only the effects of climate change on health systems, but how health systems could transform effectively to face climate change. Not just build stronger buildings, health centers, or hospitals that can resist their struggle with their environment, but actually transforming the human nature and the social nature of health system to face those climate change issues. And I think that we haven't looked into that a lot, and health policy and system research has a big responsibility. And finally, digitalization, which we all know offers also huge opportunities, and huge opportunities to conduct research differently, I think, connecting the world differently, and we need to tap into that. And indeed, I agree with Irene, just not look into the negative effects of digitalization on health systems. There are many negative effects, and we all know that, but also looking into how this tool can be used as a positive change for health policy and system research. I'll stop there, and I'll probably come back to these issues maybe more deeply with other questions.
Okay, great. Well, thank you very much, Kabir. I think it's always start again. First of all, thank you for the opportunity. Congratulations on the successful kind of session. Friday afternoons are always tough to schedule these things on, but I'm really kind of pleased to see the good turnout both in person as well as online. So that's great, and thank you for the opportunity to join the esteemed panel. I think it's great to be in such a high company. So my reflections are kind of similar to the overall sentiment that you have already kind of introduced, that every problem presents an opportunity. It also is important to kind of be clear on what the problems are and what the underlying causes of the problem are in order to find the right solutions. So I'll reflect on kind of three things, and I'll try not to repeat too much what Mariam already captured in her remarks. I mean, we all know that nowadays the rising tide of divisive politics, they constrain the sense of solidarity, the sense of social cohesion. It does decrease the public support for equity, for example, rights in many kind of contexts, the gender issues, and they kind of also contribute towards the general public skepticism towards science and health policy and systems research is not an exception. And I think that encapsulates quite a number of tensions and challenges that health systems and health policies worldwide experience. But they're also underlying the windows of opportunity that arise from there. So, for example, the issue of eroding trust and general disillusionment with establishments is actually an opportunity to engage with people as equals, to frame the health policy research as a vehicle to actually convey the messaging that actually not everything is hopeless and not everything is lost. And in many ways, I think there is research on trust, there is research on the mechanisms, how do we communicate with each other, and there is also established knowledge on how do you kind of get the messages across, so the communication, so to speak. Yet, I think it takes on average about 10 to 15 years. I think I was at a conference last time. It takes about 10 to 15 years for evidence to trickle into policy and practice. Health policy and systems research, in many ways, is a privileged field because, by definition, we work very closely with decision makers, policy makers, and that embedded nature of health policy and systems research is something that we are not showcasing probably enough to other disciplines and other fields of science. So maybe that's an opportunity for us to catalyze this translation of evidence into policies and practices a little bit more and better. The global financing crisis and withdrawal of large funders from global health clearly is an issue, but it's an opportunity also for many national research councils and national research bodies to actually stake their ownership in the research agendas. There are, of course, limits to which the different countries, particularly in low and middle income country contexts, can invest in their health systems and policy research because of lack of financial flexibility. But generally, I think there is an observation that quite few countries are below this 2% target. If you remember, in 2005, the WHO Assembly adopted the resolution that countries should, or country health systems should devote at least 2% of their national health spending on health research, and health policy and systems research is part of that. And not everybody is reaching that target, so maybe just a reminder of some of the global frameworks would be useful at this point to kind of facilitate and catalyze this sense of ownership. I think the AI digital kind of transformation is a well-known kind of opportunity, and I think Mariam has mentioned already to some of those kind of issues. But what is probably often taken for granted is we as researchers, or we as decision makers, or we as policy practitioners, they have a lot of knowledge which we communicate to each other and preaching to the converted. And I think reflecting outside the box and framing this knowledge for public use is something that we are, and myself included, are not really kind of exploring and exploiting to the maximum extent yet. And what can stop us from engaging effectively with, for example, social media, professional media, and various other outlets. I think all of us do that in our personal capacities. Various projects, they do that in a kind of sporadic way, and various networks do that for the sake of boosting their profiles. But having that concerted framing and sort of consistent agenda is something that may catalyze this kind of evidence for public use issue. And lastly, I think HPSR, as with any other research, is not neutral. It is shaped by values, it is shaped by power, it is shaped by politics. And I think, well, the classical example is the UK health, global health funding research landscape. Just to give you an example, the UK government has reduced the spending on overseas development assistance, and the current funding, for example, from the Department for Health and Social Care and the NIHR is now prioritizing global health security. So the whole overarching kind of framing of global health program is underpinned by global health security, which follows the rhetoric from across the Atlantic, but also within the Europe too. Is it a problem? Yes, because schemes such as the health policy and systems research are no longer operating. Is it an opportunity? I would say this actually presents a really interesting window of opportunity for health policy and systems research to almost embed itself within, whether it's a global health security agenda or whether it's more clinical agendas. And I think we were having these conversations over the years at the Health Systems Research Symposia and various other fora. So from that perspective, I think it's important not to see health policy and systems research as a elite kind of a distinct and discrete field. And I would advocate for HPSR to be very much welcoming, all-encompassing, cross-disciplinary, cross-boundary spanning kind of field. And I don't think we're doing enough of the latter. I will stop at this point and happy to engage at a later stage.
And that's a great point at which to segue into the discussion on power and politics. I think that's crucial here. Irene, would you have any reflections on what we've just discussed?
It's been such a rich contribution. Maybe what I'll do is I'll almost use a bit of an illustrative case study, because I think the first thing I would like to say is I agree with the things that have been said. So if you look at how do we move on, the first thing I would like to say is that repeating solutions that have been used over and over again and are not working won't solve for the same problem. Is a sure way of not solving the problem. So it gets to a place where you have to ask, how do we get out of gridlock? And I'll use a real example to illustrate the points I'm making. The first one is that sometimes we don't like to talk about our failures, but success is often failure turned inside out. If you know how to learn from your failure, how to be a learning health system, a learning individual, a learning organization. You know, in Ghana in the 1990s, most people don't know it. My colleague, Dr. Coleman, was actually posted to that unit for a while. I keep telling him he should write it up. He's not writing it up. I don't know what to do about that. But I do know what happened. Ghana actually tried to set up health insurance. But what happened was that the unit was put in, the person put in charge believed that health insurance means social health insurance. So they were trying to make social health insurance work in a low-income country. Ghana was a low-income country then. Lots of money was spent, lots of consultants, not a single person was insured. Now, it was and like I said, people keep failure under the blankets. Roll forward to a few years later, again, an effort was made in the Ministry of Health to implement health insurance. And again, the leadership tried classical social health insurance, bought software, employed people, nobody was insured. At the same time, and that's where I said to break out of gridlock, you really need to learn from everything. At the same time, people on a small scale were doing community-based health insurance in the Catholic hospitals in the Eastern region. When the insurance scheme failed, some of the people in the public sector said, let's try something else. They were on the margins, but they were trying it. So when it became a national issue, that's where we were also trying community health insurance. there was a gridlock again in the Ministry of Health. And sometimes you need insider knowledge to be aware of these things because two very powerful individuals had different perspectives. On one side was the head of the health sector, who was a firm believer health insurance means social health insurance. And the reason why I'm going on this is also to break out of gridlock. Sometimes you need to think beyond fixed categories and move beyond what we have always known and ask, do we really need to do it this way? And then the director policy was coming from a background of being a district director, being a regional director, knew all about the community insurance schemes and felt that's the way to go. I was on a committee which was trying to draft the policy, and I stopped attending meetings because each time it was a merry-go-round. You know, we never concluded. So after not attending for about 3 weeks, two colleagues came to see me and said, why have you stopped attending the meeting? I said, it's a merry-go-round. We never arrive. We have a discussion. We take minutes. I used to take the minutes and I looked through my minutes of the last 3 meetings. I had a small baby at that time, sitting in the Ministry of Health late in the night with a small baby. It's like, forget this. I said, well, you know why we are there? We have gridlock. The two most powerful individuals are convinced that it is either or. It's like, really, is that why we are gridlocked? That you have two people locked into a way of thinking? Can we think through this again? Don't tell any of the two powerful people, won't get anywhere. Why don't we, the more technical advisors, sit and think? And at the end of the day, what we suggested was that, you know what? You want social health insurance? Sure, you can have it. About 10% of Ghana is in the formal sector. They subscribe to social security. They're on a database. They have an employer. They have a salary. Let's agree on what percentage of their social security goes into the National Health Insurance Fund. 90% of Ghana is not there. And we have the failures from the 1995 scheme and the failures from the 1998 scheme. Social insurance, who never registered a soul. So that both knowing the failure, learning from the failure, being able to keep presenting the failure, being able to think outside the categories that this is tax funded and this is contributory. And we said, even if we use taxes, let's still call it insurance. And that's partly how Ghana ended up moving forward and getting a national health insurance scheme. In fact, 70% of our scheme is tax funded from VAT. But there was no point getting bogged down on, is this tax funded or is it social security? There were debates on radio with, people going, this is a tax, and people, no, it's a national. It's like, you're wasting your time. Can we focus on the core issue? So the point I'm making with this lengthy example, let me summarize it, is that one, know about your failures as well as your successes. And don't run away from facing your failures and letting your failures be seen. It can be so hard to be criticized, but sometimes out of that can emerge the learning to break gridlock. And then number two, think beyond already existing categories. I think right now the world no longer is fixated on, is this classical insurance? Is this tax funded? They just talk universal health coverage. But back then it was a real issue for some actors. So I'm kind of supporting all that I said, but I thought, let me use a rather long story. Sometimes the stories are easier to remember. Thank you.
Thank you, Irene. So I think we had the benefit of hearing what happens behind the scenes in policymaking. That was a fantastic example. Thank you so much. It also reminds me of a story which I'll say very shortly, very briefly. It's, investors who invest in health system strengthening always want to know their return on investment. And when I was at WHO, I was part of a process where a group of very powerful health funders, sort of the major health funders all over the world got together and set up a consortium to analyze how their investments on health system strengthening could create a return on investment. And the pressure to return positive results and the sort of evaluation pressure is so high that I think it will be very, very difficult for anybody to return an analysis of failure. And I think it's a real lesson for the funders of health systems to hear this message, that until our field can honestly and genuinely talk about failure, we will not see health systems improving, because the only way health systems are going to improve is through an acknowledgement of failures. And of course, small short-term failures do not mean long-term failures. They actually contribute to long-term success. So I think that's a fantastic message to move into the next phase of our session, and that's going to be with Renee and Keith. If you wouldn't mind, both of you putting on your cameras, and I will frame the question for you and hand over to you. So Renee and Keith, this question is about whose knowledge counts when it comes to health systems research and decision making. What kind of partnerships and what kind of participation are needed for the future of health policy and systems research? Let me hand over to Renee first. Renee.
Thanks, Kabir. Hello, Irene. Hello, Talib. Hello, everybody in the room. And as others have said, it's great to be together with you. So yeah, it's really difficult to answer this question in a few minutes, but let me try. My perception and my experience is often aligned with what I've read from Anthony Kingdon, who says that change happens and windows of opportunity for change are utilized when you have this convergence between social, technical, and policy streams coming together around the same ideas, around the same way of moving forward, and then can tap those windows of opportunity. And I think what I would say is that at the moment, what we've seen over the last century or more is a kind of advance of the technical stream and a falling behind of the listening to the social and some degree the political streams. And therefore, we don't have convergence. And I think we have the kind of situation Irene was talking about, where things go around and around in unproductive circles. For me, I think it really raises a demand in health policy and systems research for that listening to the social dimension and bringing it in a convergence with the policy and the technical dimension. And that's, of course, for more constructivist, more participatory, more reflexive methods that can access, organize, and use this kind of experiential and subjective knowledge. And I won't go into detail on that because I think there's quite a lot written and known about it, these approaches. Things like participatory action research, where people where the methods for generating knowledge and evidence are actually able to learn from, they're able to systematize experience, they're able to enable people to problematize, to understand action and identify action and to learn from action. But most importantly, I think, is to bring them into the center of the change process. And I think Mariam was talking about how, we've excluded, or in the political economy, we've kind of forgotten about the social dimension of health systems. And actually, I think this is not only relevant for the Global South, but it's actually relevant for all regions globally. In fact, some of the most interesting developments have come from the Global South in bringing the kind of technical and social and policy streams together. And why do we need this? I think on two basic points. One is people have a right to influence decisions, resources, and actions that affect their health. And we sometimes forget that. And states and health systems actually have a duty to create the space for people to exercise this right, to be informed, to co-determine their systems, and to hold the system accountable for its performance. But also, I mean, there is a lot of evidence of the use value of bringing the people to the center of our knowledge systems in health. Right from early days of the more holistic understanding of health that combined in Buen Vivir, in Ayurvedic, in Ubuntu and others, that sort of combined the physical material with the social, with the natural world, the natural systems, which we're rediscovering today around planetary health and syndemics and quality of life frameworks and so on. And then, the kind of exposure of varied realities that's been going on for over a century, whether it be in workplace health or extractives in health or delivery on service entitlements or giving voice to addressing inequities, to policies that are more responsive to cultural issues in health, such as the intercultural health approaches that recognize indigenous knowledge systems in Latin America, or the kind of mechanisms that enable people to bring evidence to planning, such as we've done in our region around how commercialized funding arrangements are affecting primary healthcare. And I think these things are actually exposing and energizing response and confidence to respond around inequities that exist within countries in our health systems. And it's particularly important for the fact that we are losing this social and people-centered dimension of health systems to commercial and powerful private actors and artificial intelligence and some of the things that were raised earlier. So you asked me about what sort of partnerships, and I'll end on that. What kind of partnerships and participation? And I would say 2 points, and maybe we'll have time to talk about this a bit further in thinking about how we strengthen the work. One is, I think we have to recognize and invest in the spaces and the time for relationships of trust and respect in our health systems. We've tended to put a lot of focus on commodities, on money, etc., and almost discounted the importance of these relationships. And then secondly, to invest more in this important two-way link between participatory democracy in our health systems and participatory research in our health systems, and particularly in the kind of spaces and mechanisms we have for exercising it. And I love the fact that Irene brings a concrete point in. I'll give you another concrete point around that. We currently on the middle in Africa, in a number of East and Southern African countries, I can't say it's a negotiation. It's a kind of a power exercise on accepting America First global health strategies that in 19 East and Southern African countries have already accepted them. In only one country, in Kenya, is this actual agreement in public domain? Are people able to interrogate it? And that's only because the consumer movement in Kenya took a constitutional court case against it. So I think what I'm trying to say here is that at great risk, at huge risk to our health systems, because these are 25-year agreements, this is happening in other parts of the world in other ways, are we losing the social dimensions of our health systems? And I'll say more about where I think we can strengthen it later in the discussion. So over to you.
Thank you very much, Renee. Can I hand over to Keith for his comments?
Yeah, thank you very much, Kabir and everybody. I'm very glad to go after Renee. So Renee, I'm sitting on the southern tip of Southern Africa, in South Africa, and I'm sitting in Cape Town. And being the head of the health system since the first day of COVID in the Western Cape, I'm currently the responsible person that is entrusted with the leadership role to be the custodian of a provincial healthcare system. And I'm very glad that the question that you ask, I'll take it in reverse, Renee, in the way that you've answered it. So my thing is, before you can even start talking about whose knowledge and who's involved in HSR and decision-making, you should start with the kind of partnerships and and participation that you require. And in a moment like this, I'm very glad you used that example, because I'm going to end off with an example of the withdrawal of PEPFAR funding in our setting and how that has galvanized a return to social solidarity in our context. So if you ask about what is the partnerships of participation, it has to be premised on the relationships of trust. It has to be a non-negotiable. And therefore, partnerships that is designed for extraction, partnership that is designed for exclusion, partnership that's designed where there's no transparency and no honesty, is not real partnerships. So how does this field and the players in this field actually go back to those first founding rules of inclusivity, honesty, and fairness as the basis for determining what kind of partnerships and participation is required? If we take that specific issue, then I'll step back into whose knowledge counts. in decision making and HSR. Because if you use that as your basis, and it's a value set of involving and including people, then when you talk about whose knowledge, the primary people whose knowledge counts is the people that's affected by a healthcare system. In our context, we have reached consensus in our setting that the primary focus of our healthcare system is the household. It has to be the people that suffers ill health or is in need of well-being. And we've actually galvanized our social determinants, our UHC reform, our service reform, and then the governance reform that goes with it around the needs of a household. And we located it in something, around the life course. So if I have to go back to whose knowledge counts from that household, it's all the people that support and are working in partnership with the household. So I'm back to your issue that actually working in a healthcare system, you cannot escape power and complexity. You have to engage it in a very pragmatic and real way. So let me use the example of the PEPFAR funding withdrawal in the South African context. So in the Western Cape, 20% of our HIV resources came from PEPFAR funding. So when that, in 2025, when the withdrawal was announced, I think there were two questions, and it goes a little bit back to Irene's reflection. So 20%, Rene, is not probably what the percentage is in the other Southern African countries. I know that percentage in Mozambique and all the other countries were significantly higher than 20%. But because it was 20% in our context, our first response was, okay, how are we going to deal with this issue? I can tell you, without taking a long part of it, it has been a galvanizing event to say, where in our relationship with PEPFAR did we lose the leverage to be in charge in our own destiny of making our own decisions? And tracking it back, we had touch points where we could have learned to say we could have taken different directions, but it became convenient to have the PEPFAR funding and to live with it. One of the things we did is we never allowed the PEPFAR funding to determine our data capability and our knowledge capability. So we actually have it. And actually what we did is we got the PEPFAR money and we just processed our data capability into the reporting system. So when they ripped out the PEPFAR program, we didn't lose anything because our data wasn't dependent on the data that they were collecting on top of the data systems that we had. So I'm just using that as an example. But the biggest thing was we went back to basics. We did a household survey with our community partners. We did a household survey with our civil society. And the civil society solidarity that we've built out of this was to go back to first principles and to say, let's listen to the health and well-being needs of people. Let's take a longer term view. Let's move towards sustainability and really involve and use this opportunity to pivot to what in essence have become a full transformative movement for health and well-being in our setting. Thanks. I'll hand back to you guys.
Thank you so much, Keith and Renee. And really, that note on really contextualizes the current decline in the balance between global aid and domestic financing that we are seeing. And I think that's also a really critical cusp, which is reflecting the changes that we are seeing now. Can I ask our panelists online or in person to respond to those comments made by Renee and Keith? Tolib, maybe starting with you.
Thank you very much, Renee and Keith. I think these are really important points. So there is a kind of a movement towards the decolonization of global health. I think is underway, so there are quite a number of facets within that. And those are quite a number of issues which are kind of interrelated that you both touched upon. So some of those relate to who owns knowledge, who funds the knowledge, where the knowledge actually is stored, and for which purpose the knowledge is actually used. And all of that actually operates within health systems and complex adaptive research systems that are kind of engaged within the political environment, within the the fiscal space, within the ideological space, and none of this is value free. So from that perspective, I think even the types of knowledge that are being kind of produced, they often reflect the social biases, the funding pressures, the opportunities that researchers do experience. As we all know, we apply to the available funding calls where, as and when they come. And I think what is often, and you, both of you alluded, what is often implicit rather than explicit is this demand-driven knowledge generation. So it's the knowledge that is actually being driven by people like yourself, Keith, people who are at the front line of the policy and practice, who are actually supposed to be posing questions. And as researchers, I think we are not always listening to kind of demand-driven knowledge generation, partly because funders don't always kind of frame it that way. So the funding calls or the funding schemes or even the kind of various programs, they do not always encourage that. And of course, what you mentioned in terms of kind of North-South partnerships, South-South partnerships, and also North-North partnerships are critical in terms of kind of power imbalances or balances, as well as kind of distribution of roles and responsibilities and appropriate credits for all of those activities. I'll stop at this point. So this is a long version of the short answer. Very much agree with everything that you said.
Is that, do you hear me? It's always a little bit weird to be online. Yes, okay. If I wanted to react after Tolib on Renee and Keith's remarks, I just keep it short, but there are two aspects that really is striking to me. This failure analysis, or the need to understand failures, is also something that we have been repeating since many years, let's say even decades, given the white hair we all have now, at least me. But what I have experienced as someone who's been sitting to advise policymakers in different countries is that there is a reluctancy from policymakers, with the exception of you guys sitting here who are sort of exceptional policymakers, but that the average policymaker is reluctant to hear from failures, and they want to look at success stories. So I would say that we need to find, as you know, health system researchers and advisors to policymakers, need to find a way to frame the failures behind the successes, because the policymaker will not be very receptive to hearing about failures most of the time. They want to hear about success stories. But as you said, behind every success story, there are a number of successive failures that we need to look at. So it's really how we frame it as health system researchers, as authors, as advisors to policymakers, how we actually bring that conversation on the table. Starting from the failure is removing hope from the conversation. Starting from success is bringing that hope. And then we need to unpack like a fishbone analysis. Then what is behind the first level, and then the second, and then the third, and then the fourth, and then until the seventh, until we understand the pathway to that success. Because the success itself doesn't say much. It's really the pathway. That's my first observation. And the second is, I do see now a kind of a new tick box that some donors are putting into their, it's been there since a while, but it's coming back really like in fashion, is the community participation. And I do believe in genuine trust building participation in health systems, of course. But what I see is also a tendency to put that tick box participation as a KPI or whatever reporting, donor tick box, and then it is doing more harm from what I see than good, because then there is a necessity to do community participation, and there is an imported model from somewhere else to do community participation, and we see things sort of reviving old things that have failed, that we know are not working, reinitiating some community agents that were not accepted by the community, but we need to bring them back because this is what we have right now. And in this donor funding, there is a need to do community participation. And that is really worrying me a lot, because if I put that in perspective of what you're saying, which is essential, that we need to invest in building trust in the relationships within health systems, it has to come from within. It can't come from imported donor-funded models. And we really are struggling with that at the moment. It's a vicious circle that we may need to want to break before it's actually doing a lot of harm in the health systems. Thank you.
Thank you so much, Mariam. And from that experience of having led a WHO office in a country and seen the ill effects of tokenistic approaches, and sometimes we strip the meaning of certain interventions when we convert them into targets or checkbox items that need to be completed. I just want to acknowledge that we have a number of people online, and just to encourage them to please put your questions into the chat box, and we will be taking them now in the next and final session. And of course, if any of the faithful who are gathered here today have any questions, please do raise your hands as well. I know it's late on a Friday afternoon. We really appreciate that you're all here. And that's a good segue, I guess, into the next question, which is on the future of the field and on how we should be looking at innovation in the field of health policy and systems research. And I think really this is where we would invite very brief interventions from everybody on the panel, and so that we then have a little time left for questions that remain. I'm happy to go in reverse order this time, if everybody is happy with that. And if we could invite maybe Keith to talk a little bit about what kind of research and evidence does he think is most relevant now and most innovative now. Keith, if you're ready, we're happy to go with you or with Renee.
I'm happy to go because I'm going to throw a little bit of a hand grenade into the conversation. So my first conversation, because I've listened intently to all of you, and when we say what's the future of health, health systems policy and policy research, right? The question is, who are the practitioners, the policymakers, and the researchers, and what's the relationship between them before you start talking about what is innovative research and how you go about it. So I've been, Kabir, been attending many health systems symposia events as a policymaker. And I'm struck by how the field is predominantly populated by researchers. There's been a few attempts by the Alliance to get policymakers' voices into the field more directly. I mean, I'm actually sitting in our setting, and we are saying that actually a lot of rethinking the field is the fundamental future for this field. And that practitioners, people that are the people, Mariam, that you're talking about that should be trusted, that's part of this, should be seen as health systems and policy researchers themselves. So this is this issue about the distance between the researcher and the policymaker and the practitioners. That's my first provocation that I'm putting on the table. And if we are talking about putting the, let's call it trust at the center of the system and the people mostly affected, and we talk about power, we need to actually start looking at how does that relationship function. Because who funds the health systems policy predominantly? You made the point, Talib, about South-South relationships. I mean, Irene, you were talking about that extractive relationship with our brothers and sisters in other countries in Southern Africa. So there's a whole thing about South-South relationships. It's around the voices of people that are actually affected by this research and how prominent they feel in this. And for me, the biggest innovation, Kabir, is actually to hear the voices and the questions, not even from somebody like me, but the people that are actually affected by health systems and the functioning and the dysfunction of health systems. So what does the research agenda look like? That is community-led, that is driven by people within the context where they generated, and that actually is the field brave enough to go into that space, to actually ask some uncomfortable questions of the people in the field about the future of the field, if that makes sense. Thanks, Kabir.
Thank you so much, Keith. Renee?
Thank you. It's great to follow you, Keith, this time. Yeah, I think a couple of points. One is, who is the we when we keep talking about we need to do this, we need to do this? And I would agree with Keith that unless the we is much more directly involving the very people who are affected by the system and implementing the system, then the we is floating above the reality, and we're constantly going to be reproducing problems rather than, and I do see that tokenism is not just a problem of funding agencies, it's also a problem of scientific communities as well. I mean, we've had with online processes now so much data extraction through online processes that claim to be participatory because they have a Zoom meeting with 30 people in a room. We have to self-interrogate and be very critical about what kind of research is going on that is not tokenistic. Because it generates distrust and data rates, and I think for the South this is particularly important, something we're struggling against. But we also have to take, and I see this in the South and in our communities that we work with, the social organizations that we work with, the frontline implementers that we work with, and the institutions that we work with. We have to take responsibility to be our own liberators. I mean, I appreciate this movement on decolonization that's going on, but quite a lot of it is top down. And I think our lesson from our region is that decolonization happens bottom up from the people. It's a form of mental liberation, emancipation that Paulo Freire was talking about, that then translated in Latin America, certainly into the models of participatory research that have been very powerful there. So I think we need to go back into these more rooted processes. And for that, we have some challenges. I mean, we do have to recognize the kind of risks and challenges that people in some settings face when they do this kind of work. The issues may be sensitive. We're talking about people who are migrants or discriminated against, etc. And that demands time and space, which we often lack the domestic resources for, but it also demands a high level of activism and voluntary nature in the process. We also have to build some stronger methods for learning from action that are participatory. This is something we're working on right now in thinking through how we use more realist evaluation of what worked for whom and how, but in a participatory way. And I think there's a whole process of thinking about participatory, realist, and transformative evaluation, something that's aiming at change by the very people who are involved so that we can give methods to people who want to do this kind of work, and that they can generate their own innovations around these methods. And we have to think about, it's something which we're also trying to do, is think about how we move from the local to the more wider cross-country, cross-region information and research that is actually based on the ground. because the internet is offering opportunities for this, but our methods have generally been built around local settings. So we have to really work on that aspect of it, meta-level participatory analysis. But I guess my last, and of course the spaces for exchange. We've tried, for example, in Equinet to create spaces for exchange, to allow people to publish and print work that is not accepted by the formal journals because it's coming from local settings and they think it's not innovative knowledge, but also to enable that to get into some of these formal processes. But I would say that for the South, I think we need to assert. We need to assert a situation away from the kind of north-south core periphery type knowledge approaches that we've been constantly involved with, to an idea of circulation of knowledge, which is actually happening, not just south-south, but actually south-north. I mean, we have things like the Friendship Bench around mental health in Zimbabwe that's now being used in the US, etc. I think a lot of things that were innovated in the South are now moving into underfunded systems that have had decades of austerity in high-income countries. So I think we need to very strongly assert this notion of a model of circulation. And in a model of circulation, you're actually talking about different kinds of sources of evidence and sources of information. And, sort of claim a knowledge system that looks completely different. I would say it's not just decolonize, because that's a reactive form, but something that's asserting a different kind of global knowledge that is important for health. And I'm afraid there's not enough time to go into it, but we'd be happy to talk further on that. Let me stop there.
Thank you so much, Renee. Before I hand over to Mariam, I just wanted to bring a small observation on the digital aspect that I think was alluded to before as well. I mean, we are obviously living in a very different world right now than we were living in 6 months ago, let alone 5 years ago, with the emergence of AI and digital platforms. So, I mean, maybe we could just think a little bit about that as well. I think it's like, as people say, that books were as revolutionary as AI is now, and it is another medium through which we can both undertake exploration, analysis, participatory research, and also action. So it would be great to hear reflections on that as well. But first, over to you, Mariam, for your reflections.
Thank you, Kabir. It's interesting, Renee. You said what works for whom and how, and I had just noted as my first point, what works when, for whom, and why. So I think we're converging on that one, with a few grammatical differences. I think that what it means is that we really need to not shy away from complexity, and this is very difficult because, again, we've been saying that for decades and decades, that we shouldn't shy away from complexity, and when we've been producing handbooks and methods, approaches, etc., on how to handle that complexity. But we and as I said at the very beginning, we have produced those methodological approaches. We need to up our game and use them now in our health systems, instead of leaving them in beautiful guidebooks and readers and etc. That the Alliance, for whom I worked for many years, is very good at supporting and producing. But then, how do we actually make sure that these are used in health systems and produce rooted processes and results? That's one. I have 3 points. Second is to produce real-time adaptive evidence through embedded research. I really think that we need now to move from building health systems, strengthening health system, towards supporting health system to navigate through uncertainty. This is what our times actually call upon. And from what you would just say, Kate, for example, about how to sort of face the PrEP funding cut is exactly that. How do we support health systems to move through uncertainty and to remain adaptive to population needs? And that's through embedded research. That's through real-time evidence, not something that is going to be published and then give sort of a career pathways to researchers and then bring something in 10 years from now in the body of literature. No, really now what is happening in our health systems and how to face it and how research can support health systems to move towards. And third and last, the conclusions and recommendations of research need to be grounded in political and institutional context. I always remember when I was in Cambodia, I remember Singapore researchers consistently repeating that medical savings account works for us, it won't work for you, it may not work for you. They were sort of producing evidence on the medical savings account, publishing on it, and consistently saying, be careful. We do have a very specific context in Singapore, very specific institutions, and that approach works for us. It may not work in other countries. It will not work in other countries as it works in Singapore. And that is something that I remind very well, and we really need to consistently do that, because we want to conclude our research by saying this is working and we want the whole world to adopt it. But no, it may not actually be relevant for other political and institutional contexts. Thank you.
Thank you so much, Mariam. We have some really thoughtful questions coming through. Maybe I can mention a couple of them, and before I hand over to our in-person participants for more reflections. The first one is interesting. Talking about failures, could you please mention some ways in which we can help discover the failures during health systems transformation? So how can research help us understand failure better? Is research geared towards thinking about success rather than failure? And the other question is from Mary Muturi, and that is that we hear about so many good policies on paper, but the actual implementation and follow through just isn't there. How do we effectively follow through? And very interesting point, how do we balance a fast-moving world with slow-moving policy processes? Okay, so those are just some things to reflect on, but if you want to make broader points as well, I invite you to do that.
Oh, thank you very much. I think the advantage of going after Mariam, Renee, and Keith is that all I need to say is just I agree with everything, and that will capture it. But I do want to amplify a couple of points. I think, well, first, big nod to people-centered, people-driven science. I think that's fundamental, and it's not just about kind of acknowledging people as beneficiaries of knowledge, but it's acknowledging people as essentially kind of sources and also advisors and users of knowledge. And I think that's the key there. I think what the previous panelists have mentioned is the very delicate kind of balance between context specificity of knowledge, what works for whom in whatever circumstances and why, and the kind of transferable frameworks and models and theories. And that's quite a delicate balance to to navigate, because on one hand, you want to be fully embedded within the context, but on the other, you would want to learn lessons that are transferable. And I'm trying to avoid the word generalizable, because many people would possibly disagree, especially the social scientists, with such a framing. But it's and within the health policy and systems research, I think we have been well ahead of many other fields in bridging that delicate balance. So to be fair, I think there is a lot within the HPSR that we can showcase to other disciplines. And that is something that I don't think we're doing enough. So rather than kind of generating more and more kind of innovative approaches for ourselves, and it be almost to embed some of the existing knowledge and experiences within clinical sciences, within further fields as well. And that kind of leads to another point, which I think was raised early. It's that thinking outside the box and kind of breaking the silos. I can't emphasize enough my kind of encouragement and plea to engage with more kind of cross-sectoral, cross-disciplinary approaches. I think there is a huge potential. I think, Renee, you mentioned some of the innovative methods, participatory realist evaluation. One or two colleagues also I think, published one or two papers on participatory economic evaluation. So those are the kind of fascinating examples of thinking across the different boundaries and engaging with those. And maybe the caveat there is interdisciplinary work is not easy because, for example, within the field of health research, the journals, they are not geared towards such pieces. They're very much constrained by the boundaries, even though some of the research funders encourage on the surface cross-disciplinary approaches, but they are really health funders or education funders or whatever, clinical funders. So from that perspective, I think there are limits to that, but all we can do is collectively advocate and push that agenda forward. And I think the nature of cross-disciplinary work also differs quite significantly from linking, nesting, embedding, collaborating, and all the way through to transdisciplinary work, where people are driven by the unified theoretical frameworks, where the conceptualization and value-driven approaches are embedded within each other, rather than kind of borrowing ideas from across the different fields there. And I think and I'm not sure if that's an innovation or perhaps reflection on the current tension, is this delicate balance between short-termism and the desire to actually enact the longer-term change with the strategic trajectory in mind. Quite a lot of project-based efforts, they are typically limited to what, 3, 5, maybe 7 years at tops, whereas actually health system strengthening is a much longer endeavor. And of course, we're constrained by the election cycles of the politicians and kind of limits to the project-based funding. But perhaps an innovation would be to ensure that institutional memory, continuity of the agendas, and make sure that the agendas are really taking forward. I mean, in the spirit of kind of giving examples, I'll give you one example from the Nigerian context, where actually in 2010, we started a project looking at the flagship program of the previous government, which was the kind of fuel subsidy reinvestment program into the social sector. And then about 2 years into our research project, it was incidentally a realist evaluation project, the government changed and the new government abolished the program. And then a year after they came into power, the new government actually instituted pretty much the same components of the old program, but under the new flag, under the new banner. So, of course, the credit went to them and but the moral of this story is, I think there are opportunities to speak to politicians. There are opportunities to bridge that short-term versus the longer-term trajectories. But of course, there is also space to avoid those longer-term pauses and make sure that everybody is given due credit. I'll stop at this point and back to you, please.
Thank you. I think I'll just comment on one issue. And I think the question was about the future of HPSR. I think, increasingly, I see for HPSR grant funding, or HPSR, because it's an applied field, funders want to know research uptake and how you have influenced policy, practice, implementation. The reality is that it is a social science and it is a soft science. I see all kinds of statistics, you know, how many policies have you influenced and what has changed. And I think it's something that at the global level, there may need to be some education to really I think people don't understand the field. And it's not just the funders, also the researchers themselves. And without that education, I come back to Renee's issue about relationships, trust, and respect. Because then you have researchers desperately organizing policy dialogues and policy briefs and trying to log how they've influenced policy. But I've spent my life working in practice as well as in research. And my observation is that it takes time, it takes trust, it takes relationships, and it also takes recognizing windows of opportunity. But when a window of opportunity comes, and it requires being embedded and deeply engaged in the system, and it also requires really caring about the system. And that brings me to the next issue, is that what are the incentives? Often the incentives are driven by a funder requesting that you influence policy. And the researcher is also being pulled by their academic institution, requiring that they attract a grant and they publish and they are well cited. They are conflicting incentives, street level bureaucracy. People will adapt coping behavior, and that's why you get tokenistic approaches. They have to cope. And I think we need to push back. There has to be a pushback. It's that problem is coming because people are concerned that research funding doesn't appear to be changing things. But then people are in there for, I think Talib mentioned, 3, 4, 5 years. Sometimes it is changing things, but it's one ingredient in a meal. So who is going to take credit for the whole meal? And if you walk out of the kitchen just when they finish slicing the onions and tossing them in the oil, which is probably what happens when you walk out after 3, 5 years, and somebody else comes in and buys the tomatoes, and then they walk out just when they are adding I'm talking about Ghanaian gravy, and somebody else helped boil the meat somewhere. Finally, down the line, when the gravy is ready, you won't know that you contributed to it. And I think one of the challenges I'm going to throw to the field is, how do you get this understanding among researchers, among funders? And also, how do you get national governments in low and middle income countries to understand that despite their constraints and their struggles, if they would only fund a bit of this field? And my last thing is that you need to build some of the research capacity within the health system itself, so that there's a partnership between people who are engaged in the health system and people who are engaged in academia. Otherwise, the tokenistic approaches are not going to stop, and we're going to stay on this merry-go-round of doing the same old things over and over again and getting the same old results. Thank you.
Thank you so much. I wish that could be the last word, but I do have to give thanks to everybody. And I just want to actually just reiterate one of the things that you brought up, which is about the importance of the field. I mean, I think it's as people who are involved in health systems research, we've all experienced this challenge of, on the one hand, we have to do the research, and on the other hand, we have to explain to people why it's important to do the research. So there is a little bit of a double whammy there for everybody who is in this field, which is really interdisciplinary. It's liminal. It falls between many different stools. There are no research councils for health systems research. There are no big funding schemes for health systems research. The ones that were there are now eroding. So I think we sort of need to keep making this point. And I think health systems research has over and over again shown its utility. But I also think that as people involved in health policy and systems research, we're not very good at communicating the fact of what we do is significant and important and useful. I think we need to become better at communicating our research. I think, of course, that's a message for all researchers, not just health policy and systems researchers. but we need to embrace new ways of communicating research and new ways of communicating research that was done well. And again, would reiterate, I think we really need to learn from maybe some of the new generations in terms of how we can communicate those messages better, especially using the new modalities that are available to us in doing that. So I think there's a lot to take away. It might seem like we're all talking within ourselves, but I do think this is a really important conversation. There is going to be a lot that comes out. We will keep having these conversations. Of course, please do come to the Global Health Systems Research Symposium, which is the premier forum for these discussions. And Tolib is the current chair of the symposium and the society. We are still working out the date and venue, but it will be known shortly. And we are also working together, all of us actually on this panel, on a book which will be a research handbook on health systems of the Global South. So that will hopefully become a compendium and a resource for other people doing work in this area. And maybe finally, a reflection on the overall balance of the world that we're seeing now. And we're seeing a disinvestment from the global development model, a disinvestment from multilateralism, and at the same time also a decline in science funding. And hopefully this will, lead, as in crisis there's opportunity, we might see an opportunity where more low and middle income countries pick up this mantle of supporting meaningful health systems research, funding meaningful health policy and systems research in that serve domestic needs and the needs of their learning health systems. So I just want to finish by thanking everybody who's been involved, particularly Madhu and Hitsa, Tamar, Weihao, and all the other volunteers who've been very helpful. Thank you so much. And thank you to everybody who's joined, to our online panelists. Thank you very much for giving your time. And to Tolib and to Irene for being here today. Have a nice weekend, everyone. Bye-bye.